So we will now learn how to manage the depression of the CNS. Depression of central nervous system is generally defined as an unerasable lack of awareness with a rating of less than 8 on the Glasgow scale. So the Glasgow usually for the comatose patient, best assessment of the patient of the coma is the Glasgow coma scale. It is often used and you must be knowing how to use the Glasgow coma scale. In brief, I will be telling that under the Glasgow coma scale, there are the three main parameters. One is the best eye response we have to look for the E for eye, EV for the verbal response, and the M for the motor response. How they are, and then you have to look the response. For the eye response, you have to check whether the eye response are spontaneous or not. If they are spontaneous, then the score is for 4. If they are percentage opening on the speech on asking, then that is the scale is the 3. If it is not opening on the speech and it was opening only on the painful stimulation, then the score is true. If there is no response in the eye response, then score is 1. In the verbal response, if you talk with the patient, if you find that the patient is oriented to time, place and person, then the score is 5. If he is confused, then the score is 4. If he is using inappropriate words, then words are formed but they are inappropriate, then the scale point is 3. If the patient is using inappropriate sounds, then that has no meaning, then the score is 2. And if there is no response, then the score is 1. Similarly, for the motor response, you ask for the movement of the body parts. So if he obeys the commands, then the score is 6. If he moves to localize the pain, then the score is 5. If he is not moving on the pain, and then if you are giving pain, then he withdraws by flexing, then the score is 4. If there is abnormal flexion, that is the decorticate rigidity, then the score is 3. If there is abnormal extension, then the decelerate rigidity, that is the score 2. And the no response, then the score is 1. So in total, it is reported E1, V1, M1 like that. So if I has 4 score, verbal has the 5 score, and the motor response has 6 score. So totaling, it will be the total score, maximum best score of a healthy person will be 15. And according to that, when it is 8 or less, then the patient is characterized under the coma condition. And if it is less than 3, then it is totally unresponsive. So this is the way to score the patient based on the Glasgow coma scales. But in the poison cases, the European Association of Poison Center and the clinical toxicologists are of opinion that this scale, while being very useful for trauma patients, is inappropriate for case of acute poisoning. For those clinicians accustomed to applying the Glasgow coma scale to all patients with altered mental status, assigning a score to overdosed or poisoned patient may provide a useful measure for assessing changes in neurological status. But in this situation, the Glasgow coma scale should never be used for prognostic purpose. For the poisoning cases, you use this for the diagnosing the state of the comatose condition, but never for the prognosis. Because even the person who is having unresponsive after toxic injection, he may have the Glasgow coma scale of 3. Then also he will be completely recovered after the care of according to the management protocol of the poisoning. However, if the coma is due to the brain injury or due to other reasons, if a patient is in the state of Glasgow coma scale 3, it is hard chance that their prognosis is said to be poor. Whereas in poisoned cases, because of complete recovery from properly managed toxic metabolic coma, despite a low GSS, is the rule rather than it is an exception. So, most of the comatose patients due to poisoning shall come out of it very after a proper care and treatment. So, several other scales have been proposed, including reaction level scale, comprehensive level scale of unconsciousness level, coma recovery scale, Innsbruck coma scale, Reed's classification, Matthew Lawson scale, but the predictive value of all these scales remain to be uncertain. A practical guide that can be easily applied and is quite reliable is mentioned in this table, which also has the additional advantage that it takes into account not only CNS depressants producing to coma, but also the CNS stimulants producing the comas. And particularly, the CNS stimulants produces coma in the last stage, whereas CNS depressant produces coma in the initial stage. So this scale has been devised a practical scale, particularly in in the case of the intoxication. So if the person has the intake of depressants, then this 0 to 4 scale is there. At 0, he is asleep but can be aroused. If he is in semi-comatose, withdraw from the painful stimuli, reflexes intact, then the score is 1. If he is in comatose, doesn't withdraw from painful stimuli and reflexes are intact, then the score is 2. If the comatose, most reflexes are lost, no depression of CVS or respiration, then it is 3. If comatose, reflexes absent, respiratory and circulatory failure, then the score is 4. So, this scale is a better help in the prognosis of the comatose patients in case of intoxication. Further, in case of stimulants, the grade 1 is given when the person is restless, irritable, with insomnia, tremor, hyperreflexia, sweating, and mydriasis. Grade 2 is when the confusion is there, hypertension is there, tachypnea, tachycardia, and extrasystoles are present. Then the delirium, mania, arrhythmia, and hyperpyrexia are given as grade 3. Then convulsion, coma, and the circulatory collapse are given grade 4 when the CRS stimulant poison are used. Then there are the numerous causes for coma, of which one of the most important is acute poisoning. A number of substances can induce coma, and it will require a great deal of astuteness and expertise to pinpoint the poison. So here you can see a number of causes for the comatose condition caused by the toxic effects of them. So different types of coma that are produced by the toxins are the hypoxic coma, by the acidosis, by the depressants, hypoglycemic coma, by the enzyme inhibitions, post-ictal, that is after the jaundice, and other causes. So under the hypoxia can be due to the displacement of oxygen in blood and tissues that can be produced by the carbon monoxide agent causing methemoglobinemia, acetanilide, aniline dyes, chloride, dinitrophenol, nitrites. Displacement of oxygen in atmosphere may be the reason for hypoxia. They can be by the carbon dioxide poisoning, butane poisoning, propane, methane poisoning. Then the acidosis can be due to ethylene glycol, isopropanol, methanol, paraldehyde, salicylates. Depression of CNS can be due to alcohols, antidepressants, anticonvulsants, antihistaminics, barbiturates, benzodiazepines, bromides, chlorhydrates, opiates, phenothiazines. Hypoglycemic coma may be produced by the hypoglycemic drugs, ethanol, insulin, isoniazid, salicylates. Enzyme inhibition can be produced by the cyanide, heavy metals, organophosphates. Post-ictal coma is produced after the amphetamines, cocaine, chlorinated hydrocarbons, hallucinogens, withdrawal from the alcohol, and sedatives. In other causes, food poisoning like botulism poisoning, mushroom poisoning, shellfish poisoning, and even snakes, nervous system affecting snakes, all can cause comatose condition in the patients. Before proceeding to an elaborate exercise in diagnosis, however, it may be desirable to first ascertain for sure that patient is really comatose or not just pretending. That is, the patient may be of the psychogenic or hysterical coma. This is often encountered in cases of suicide gestures, in contrast to the attempted suicide. So, both the cases of the suicide gesture and attempted suicide may present with psychogenic or hysterical coma. Before proceeding to an elaborate exercise in diagnosis, however, it may be desirable to first ascertain for sure that the patient is really comatose or not just pretending, like those in the psychogenic and hysterical coma. This historical coma is often encountered in cases of suicide gesture more commonly than the attempted suicides. The former, that is the suicide gesture, is an attention drawing gambit where there is no real intention of ending one's life. The telltale fluttering eyelids, the patient who is half awake, half dragged by his relatives, an elaborate suicide note, a phone call to friend or relative informing them of the act, pill bottles strewn about, all may point to such a suicide gesture. In addition, the signs and symptoms manifested by the patients usually are out of proportion to the ingestion itself. So the question is, how does the doctor humanly determine whether the coma is true or fake? Several methods have been recommended, of which the following constitute barbaric act that must not be employed, like pinching the nipples or the genitals, or repeatedly pinching any part of the body. That should not be done. Slapping the face hard repeatedly, cotton placets or sterile applicator tips soaked with ammonia solution being inserted into the nostrils. They should not be done. Instead, the following steps are better and they must be helpful to diagnose the psychogenic or hysterical coma. Perform a quick physical examination with particular attention to the breathing, vital signs, and the gag reflex. If these are normal, the coma is almost certainly psychogenic. Another indication is that a tightly clenched jaw when attempts are made to open the mouth, then the patient will pretend that it is not opening. But before that, you must first rule out the seizure disorder. So it will be helpful that to know this is psychogenic coma. Useful technique to lift the patient's hand directly above his face and letting it drop. So you allow the hand of the patient to be raised and let it drop on his face. So he will try to avoid that thing. A psychogenic etiology is almost a certainty if the hands falls gently to his side rather than obeying the law of gravity and landing on the face. Pinching the shoulder may also be tried but must not be repeated more than twice. Some clinicians advocate rubbing the patient's sternum with the knuckles of the clenched fists. The key to successful manage a patient with a psychogenic loss of consciousness is to avoid humiliating the patient in front of their relatives, friends, or hospital staff. But once you find that this patient is pretending or making the psychogenic coma, so you must not scold them, you must not make fun of him or humiliate in front of the relatives or other hospital staffs or friends. Making it known loudly to the patient that friends and relatives are waiting outside and the poison should be wearing off by now. Explaining what has to be done and why in a firm, non-emotional tone, avoiding physical abuse or humiliation will often enable the patient to regain the consciousness over a period of a few minutes with his dignity and self-respect intact. If the patients resist all the above maneuvers and the attending doctor is sure that he is dealing with a known injection that is harmless, it is better to leave patient alone for some time. However, if there is any doubt as to the seriousness of the ingested substance, gastric lavage must be initiated, ensuring all the necessary precautions. In the final analysis, this is probably the best known of all the methods to truly awaken the hysterical patients. Hoffman and Goldstein reviewed data from 1966 to 1994 on the treatment of poisoned comatose patients and came to the conclusion that in every case where the identity of the poison was unknown, the following three antidotes were administered, that is the dextrose 100 ml of 50% solution, thiamine, vitamin B1 100 mg, and the naloxone 2 mg, all were given intravenously. So this was developed and considered as a coma cocktail. For a child, thiamine is not recommended and the dextrose should be more dilute, that is in the range of 20 to 25%. If IV access is a problem, naloxone can be given intramuscularly or endotracheally. The rationale for the coma cocktail is that a significant proportion of poisoned comatose patients in whom the identity of the poison is unknown comprise cases of overdose from the opiates, alcohol, and hypoglycemic agent. Even if a particular case is not due to any of these causes, administration of these antidote is relatively harmless. So it has been used and recommended to use them for the management of the comatose condition. Phytoestigmine must not be part of the coma cocktail since even though coma from the anticholinergic axis is also relatively common, phytoestigmine, which is the antidote for it, produces serious side effects such as seizures. It should be administered 2 mg IV for an adult and 0.5 mg in child only if there is an unequivocal signs of anticholinergic excess. So phytoestigmine should only be given if it is sure that the patient is poisoned with anticholinergic excess. Analeptics such as caffeine, picrotoxin, doxapram, nicotinamide, etc., which were previously advocated as a restorative remedies to stimulate respiration in comatose patients, must also not be used since they offer no substantial benefit and instead can lead to intractable seizures and agitation. In addition to the coma cocktail, all the patients with a depressed mental status should receive 100% oxygen in the mask with a flow of 8 to 10 liters per minute. Attributing an altered mental state to alcohol because of its odor on a patient's breath is potentially dangerous and misleading. Even small amounts of alcohol and its congener generally produce the same breath odor as do the intoxicating amount. Conversely, even when an extremely high blood ethanol concentration is confirmed by the laboratory, it is dangerous to ignore other possible etiologies of an altered mental status. Chronic alcoholics may be awake and seemingly alert with ethanol concentration in excess of 500 mg per deciliter, a concentration that would result in coma and possibly apnea and death in non-alcoholic patients. The metabolism of alcohol is fairly constant at a rate of 15 to 30 mg per deciliter per hour. Therefore, as a general rule, regardless of the initial management of the initial blood alcohol concentration, a presumably inebriated comatose patient who is still unarousable 3 to 4 hours after arrival should be considered to have structural CNS damage, that is head trauma, and or any other toxic metabolic etiology for the alteration in the consciousness until proven otherwise. So the careful neurological evolution supplemented by the head CT scan is frequently indicated in such patients who are not recovering after all the management in the alcoholic patients. There is an increasing dissatisfaction among toxicologists with regard to the actual benefit of the coma cocktail. Of the late, physicians are increasingly resorting to extracorporeal membrane oxygenation ECMO in managing profound cardiorespiratory failure from the many causes including poisoning. So with this, we finish today's class. We shall meet tomorrow with the learning of the how to perform extracorporeal membrane oxygenation and the further the last aspect of the initial resuscitative measures, that is E. With this, thank you so much for your time.